Hey guys, welcome back. I have another special guest. Today we have a pretty top-notch cardiologist, Dr. Bret Scher. So welcome. Thanks for being on.
Thank you, Eric. It's a pleasure to be here.
So you're actually practicing in San Diego. I used to live in San Diego. I used to practice there for about 3 years. I was right next to the stadium there. The stadium, and you're by the where the jets fly over, right?
Right. So we may hear some today. I have a couple different offices. One's in the Kearny Mesa area. I do a lot of online health consulting now, which from my home, which is where I am now, which does sometimes get in the way of the Miramar Jets, it seems like. But, that's the price of freedom, the sound of freedom, as they say.
That's right.
Yeah.
Well, I'm really glad that I had a chance to chat with you, simply because, I mean, you're like board certified cardiologist, and there's been some concerns about cholesterol. We're going to talk about that today.
Sure.
And you're also going to be speaking at our summit, which I'm excited about as well.
I'm looking forward to that.
Yeah. So it's rare to find a cardiologist that is keto friendly, low carb. Tell me, when you first got out of practice, like 20 years ago, I think, right?
Yeah, I've been practicing as a cardiologist now for 15 years. And of course, it was about 14 years before that of college and med school, residency and fellowship, all that fun stuff to become a cardiologist. So it's been a while now. Yeah.
I admire that. That's a lot of work. So coming out, did you were you of the mindset of just low carb, or were you just pretty much conventional, we're going to just do things according to the American Heart Association?
Absolutely. American Heart Association knows all. That's that's how I came out. And actually, my fellowship was actually in a preventive cardiology fellowship. It was a combined general and preventive fellowship. And we were an Ornish style program. I mean, we were a very low fat, high carb kind of program. And, the things that we were teaching people for exercise and stress management and community involvement, those are crucial, and I'm so thankful for the lessons I learned there. The lessons I learned from nutrition, maybe not so much. And in retrospect, it should have been a red flag, seeing how many people were struggling to maintain that type of eating, and how many people were having cravings and were just longing for the days where they could cheat and do something different. And it wasn't a very sustainable method for the majority of people. Now, what happens is some people will thrive and some people will do great. And when you're going from a standard American diet to that type of diet, of course, there's going to be a subset that feel fantastic, and most people are going to have some improvements. But the question then becomes, what's going to happen for the next 10 years? What's going to happen for the next 20 years? Because, let's be honest, I don't care what you do for the next couple of weeks or the next couple of months. I care what's going to happen for the rest of your life. And that was the impact that I saw I wasn't having. The impact on people that they can make some immediate changes, but they were coming right back having, quote, failed lifestyle intervention. And that's a term I've grown to hate, because it implies that we've tried everything, that we've tried every possible lifestyle. We tried the only possible lifestyle, and they failed that lifestyle. And that's when I started to have this little bit of awakening to say, you know what, maybe we're not doing the right thing. Maybe our message is wrong, and it's not actually millions of people's faults. Maybe it's actually our fault. And that's a hard awakening to have, as I'm sure you can imagine, to say everything I've been taught, everything I've been practicing is actually wrong. That's kind of a tough thing to come to grips with.
That's a big pill to swallow.
Yeah, absolutely.
So you eventually you just stumbled on low carb, and tell me a little bit about
Yeah, I didn't just stumble on it. So it was sort of this major transformation time of my life. The other thing I realized was I didn't spend 14 years learning to become a cardiologist so I could, plug your information into some calculator and have it spit out whether to give you a medication or not. Like that's not the impact I wanted to have on people. And I was seeing that I wasn't affecting people as I had hoped. When I came out of my fellowship and I was bright-eyed and bushy-tailed and thought I was going to save the world of heart disease, the reality was far from that. So actually, that's when I started Boundless Health, and that's when I started a health coaching program with a friend of mine, and we were working out of the basement of this gym, and he's an amazing trainer and health coach. And on some of our, more challenging clients, he'd say, hey, you should try a ketogenic diet on this guy. And I looked at him and I said, I'm a cardiologist. I don't want to kill the guy. I want to help the guy. Like, what are you, crazy?
Right.
And he looked right back at me and he says, so have you looked into it? And you know the data behind it? And I had to be honest with him. I said, actually, no, I haven't specifically looked into it. And that started this journey. I started to read one thing, then another thing, then another thing. And then my eyes got a little bigger and a little bigger. And the world opened up. And all of a sudden I realized, wow, there really is this whole other world out there that has been just demonized by the medical community and not talked about by the medical community, and for no good reason. And then once I learned about it, and then once started implementing it with the clients along with the health coach Dustin, I mean, then all of a sudden there was no turning back. I mean, once you see the way you can impact people and see improvements in their blood work, see improvements in their body composition and how they feel, and then how they're training and exercising and just being able to really transform their lives with a tool that's never been taught before, really. No, I used the word never, in mainstream practice. So yeah, that was a major awakening for me.
I mean, you're right at the cusp of where most of the damage occurs, in the artery, in the coronary artery.
Right.
From high insulin. So
right.
So here you are. You do surgery still, or stents?
So I do the angiograms where we put the catheters in the arteries, feed them up to the heart, inject the dye so we can see the arteries and see where they're blocked. Then if a stent is needed, I'll call one of my colleagues in to come put the stent in. But, the way I look at it, every time I'm in the cath lab, every time I put on the lead and put on the sterile gear and end up in the cath lab, it's because we failed somewhere, really. Mm-hmm. I mean, that's what it comes down to, because all of this, I guess not all of this, but 85 to 90% of what I see is preventable. So by the time I see people in the cath lab, I needed to see them 10 or 15 years earlier. And that's why, I still have my traditional cardiology medical practice, but where I really get the most joy and the most satisfaction is seeing people as an online health coach, where I sort of say, take off my doctor hat. Now I put on my health coaching hat. Let's talk about your lifestyle. Let's talk about your stress management. Let's talk about your nutrition. Let's spend an hour and a half talking about this rather than your 20-minute office visit, going over your prescriptions. Let's see how this fits into your whole health and lifestyle and your whole life, really. I mean, and that's what everybody should be getting. But our medical system is not geared up to provide that. I mean, let's be honest about that.
It's, I agree with that. Now, when you're, right now, do you have a chance, when you're scoping someone or evaluating someone, do you have a chance to get with them, to consult them on the diet, or are they open to it, or
Yeah, it's a great question. I mean, I can't stop talking about it. So one of the biggest questions is, are they going to be open to it? And part of it is the situation, right? When if someone comes in with a heart attack and someone ends up with a stent and they're going to have 5 new medications and their life has just been turned upside down. On the one hand, that's a great time to talk about it because they've got the sort of scare factor. On the other hand, it's a terrible time to talk about it because so many things are transitioning and, it may not be the right time for them to jump into it. So it's really, part of it is sort of reading the person to see when is the right time to discuss this. Mm-hmm. But at some point they're going to hear it from me, and I can only hope that they're going to internalize it. And I guess the flip side of that too is saying, finding the right approach for each person, because there's not one diet, there's not one exercise program, there's not one way to manage your stress, right? There are a multitude out there. And some are going to work better than others for each individual. But the key is to make them all an option. What really bothers me is that we say there's one diet for people, there's one exercise program for people. And that's sort of what contemporary medicine says. And I think that's so just limiting and so short-sighted and foolish of us. And that's really why cardiovascular disease continues to be the number one cause of death and has continued to be that way for decades. It's not like this is a brand new thing. It's been that way for decades, and we haven't had the impact that we really need to have to prevent cardiovascular disease and to help people live longer, happier, better lives.
Totally. You've had probably people do keto. Talk about what happens if their cholesterol starts going higher. They might be concerned. Oh my gosh, Is this the right thing? I'm eating all this fat. Let's talk about that for a little bit.
Yeah, that's a great point. So the first caveat is to say, when you look at the literature and you look at the studies that have been done, and in my clinical practice, the majority of people who go on keto do not get a markedly elevated LDL. So that's the first thing, because Because all you have to hear is a couple case examples, see a couple cases on the internet to think, oh my God, everybody who goes keto is going to have an LDL particle number of 3,000. No, it doesn't work that way. And all you have to do is look at the majority of the studies that have been done that show either no change in apolipoprotein B or a small change in LDL-C, but the majority don't see this dramatic rise. Okay,
So
so
I just want to, so basically, just because people are going to listen and go, what does that mean? APO
right.
this. So
sorry, I
we're
tend to
talking
throw
about,
technical terms around.
we're talking about these little boats that are carrying the cholesterol through the body. They're transport units, and they're dumping off different cargo at different places. And the ApoA is a little kind of like the driver of that. It's tells it what to do, instructs it. It's like the chief captain of the ship.
So you've got your LDL lipoprotein, and that's your carrier molecule that has the LDL cholesterol inside it. On the surface of that lipoprotein is called an apolipoprotein B, and that's sort of by definition, every LDL boat, every LDL lipoprotein has one of those ApoBs. So people tend to use them interchangeably. The LDL particle number or ApoB, you can sort of use interchangeably to talk about the number of these boats floating around. And then the LDL cholesterol is the amount of cholesterol inside all of those boats, okay? And traditionally, we use LDL cholesterol as the end-all be-all measure, but really it is a far inferior measure to ApoB or LDL lipoprotein particle number. So the words get big and it gets a little confusing, but the number of particles are more important than the total amount of cholesterol, okay? So, and for the most part, most people don't get a dramatic rise. So that's the first understanding with a low-carb or keto diet. Now, those that do, the question becomes, what does it mean? And that is a very muddy waters indeed. Because there's this teaching that have been passed down for decades that any elevated LDL is dangerous regardless of the circumstance. But the problem is any of those studies that have been done to date, not a single one is focused on people who are following a low-carb lifestyle, who are burning fat for fuel, and who are improving all these other markers of insulin resistance and diabetes and inflammation and metabolic health, and all those improving while you're using fat for fuel. None of those people have been included in any of those studies, okay? And oh, by the way, those studies show a loose, sort of a weakish association. It's definitely an association, but it's not that everybody with a high LDL is automatically getting a heart attack, right? People love to point out how many paradoxes there are. There are tons of paradoxes, tons of examples of populations with high LDLs and yet thrive and do well. So there are plenty of reasons to say there are subsets of people who do just fine with elevated LDL. So could the low carb enthusiast, the keto diet follower, could that person be one of them? We don't have the evidence to say that for sure, but gosh, there sure is a lot of reason to say it might be the case. So it's a really confusing situation because most people are going to go to their doctor, and if they have a high LDL, either out comes the statin prescription or the doctor says you're killing yourself with this diet, you have to stop. Ignoring the fact that they feel better and they've lost the weight and they have more energy and they've reversed their metabolic disease and all that, right? You're with one marker's off, so you're killing yourself. So instead, you really have to take a step back and see things from a much broader perspective and say, okay, why are you doing this? What improvements are you seeing? What negatives, I guess you could say, or have you seen, which is usually just the LDL? And then what does that mean for your overall picture? And that's when you have to dig deeper, whether it's calcium scores, whether it's carotid intima media thickness testing, whether it's looking at the size and density of the LDL and the LDL pattern and your inflammatory markers. There has to be a deeper evaluation, I think personally, than just the reflex, you have to get off your diet or you have to take a statin, because this is a very special subset population. And again, that's why I really enjoy working with people as a health coach online, because you can take the time to go through all this, right? You can, yeah, go ahead. I
was just going to say that I want to chime in because I think it's not a simple answer. There's some muddiness that you have to understand some basic physiology to really get the truth of it, because you can't even take one little indicator, LDL, and you have to look at other things as well. You have to understand the particle type and the size of the particle. So that's so true. And and I know there's people watching right now, and I'm just going to tell people, I'm going to put a link down below to your website. So I'm sure there's going to be a lot of people that want to consult with you, so they can get more information with the link down below, because they're going to probably want to, pick your brain. So,
Sure.
so I want to just shift gears to calcium in the arteries, coronary artery calcium. There's a test. Let's tell us a little bit about what that is and how that would compare to maybe other indicators for risk for heart disease.
Yeah, it's a great question. So coronary artery calcium score is a very simple CT scan, a CAT scan. Takes about 10 seconds, no contrast, no IV, a low radiation dose. Generally, people say it's about the same as a mammogram, very low radiation dose in terms of CT scans, because there are plenty of other higher radiation doses. So relatively low radiation dose. And it can tell you if you have calcium in the walls of your artery. So it does not tell you if you have plaque or buildup in the middle of your artery. So if you look at my hand here, if the middle is where the blood is flowing, and the fingers, the outside of the fingers here is the wall of the artery, that's where the calcium can get deposited. And what it tells you, though, is that there has been vascular injury. There's been some type of vascular injury and a body's response to it, which has laid down the calcium. And you can get a score from 0 up to, thousands I've seen. But they generally break it down as 0 is obviously great. It means you've had none of that vascular injury in the calcium deposition. 0 to 100 is being sort of a mild. 100 to 400 is being moderate, or greater than 400 being severe. Those are very loose definitions, and age plays a big role in that, because there's also an age percentile score that you get. Because the score of 20 in a 40-year-old is very different than the score of 20 in a 75-year-old, because it means completely different about the speed and the likelihood that you can develop injury. Okay. So what studies have shown is that the higher the degree of calcium, the higher the risk of having a cardiovascular event. And it tends to track better than LDL cholesterol as a solitary marker. It tends to track better for a one-time test than the carotid intima media thickness test. It's a very good test to get. It's so good, in fact, that the latest cholesterol guidelines by the ACC and the AHA finally recognize it as a test that should be done in the majority of intermediate risk patients to help better identify whether they are a candidate for a drug, is basically how the guidelines think about it. I would think about it a little bit differently, but it's the first time they've come out and said, look, with a calcium score of 0, you're probably not going to benefit from a drug. So statin prescription would not be indicated in that case, which is for, an AHA, ACC type of guideline, the Cardiology Association guidelines, to say that is revolutionary, really. So that shows how powerful this test can be.
That is so huge. Yeah, I recommend it to patients just because it's a quick test. It's not that expensive, and it can give you a lot of good data. Because if your score is like over 1,000, you better change. It's time to change your diet, right? Because
it's time to change something. It's probably time to change a lot of things. Yeah.
Right.
One of the hard things is, though, there's no timestamp on it, right? So you can have somebody who's been leading a standard American diet and been insulin resistant for 20 years, and then they decide to go low carb and improve their lifestyle and start exercising, and 6 months later they get a high calcium score. There's no timestamp on that calcium score. It doesn't tell you when it came up. So it could have been that it had been, a lot of people would say, oh, it's because you're low carb now that you have this high calcium. But actually, it was probably that 20 years of standard American living that caused it. So that's why some people recommend, if you're going to go low carb, if you're going to drastically change your lifestyle, get a calcium score. So you timestamp it. You have a time 0. Yeah. And then, moving forward, you can retest it again in 3 or 5 years or something like that to see if there's a change. Yeah, because otherwise there's no timestamp.
Yeah, and so basically you can't really evaluate something unless you have 2 numbers. You have to go, is it getting better or is it getting worse? So that'll tell you trends,
Right. Great point.
Do you happen to like your cardiologist friends and things, your associate doctors that you work with, are they open to it? Is it changing? What's happening in that area?
Yeah, I wish I could say it was changing and they're open to it. The vast majority are not, no question about it, because we've been taught fat is bad. We've been taught LDL-C is everything. And when you've been taught something for 10, 15, 20, 30, 40 years, and you've told thousands of patients that, it is hard to have that reversal. So a lot of people are not open to it. And, in fairness, some people would say, look, when you show me the data, when you show me people living this way for 20 years are doing great, not having heart attacks, okay, I'll jump on board at that point. But that data is hard to come by. And the data we have to this point, when you actually analyze the quality of the data for low-fat diets, when you analyze the quality of data for cardiovascular outcomes, it's really poor. But if it's all you have, and you want to be, and you want to practice according to the data, then that's all you have. But I think it's so much more important to say, what is the quality and does it actually back up the recommendations? And that's where these recommendations sort of really break down.
Wow, interesting. As far as like arrhythmias, atrial fib, things like that, do you work with those clients as well?
Absolutely, all the time, all the time. Yeah.
Do you ever have you ever done any type of your own research in doing more electrolytes, more minerals for these, since the minerals are associated with the pacemaker and the nerve conduction of the vagus nerve and all that. So touch on that a little bit.
Yeah, so one thing I see very frequently is just palpitations, sort of the general sensation of palpitations. People getting PVCs, premature ventricular contractions coming from the bottom part of the heart, or PACs, premature atrial contractions coming from the top part of the heart. And those can be brought on by caffeine and alcohol and stress and lack of sleep and other stimulants. But they can also be brought on by some electrolyte abnormalities. And frequently we are not good at testing for electrolyte abnormalities, because we can test the potassium and magnesium in the calcium in your blood, but we can't test it in the cells as well. So that's where you could have a deficiency and it may not show up. And the way our food is, farmed, the way our vegetables get to us and in our soil, we just all are probably walking around a little bit magnesium deficient. So that's one of the first steps I always have is a magnesium replacement, whether it's a pill or whether it's an Epsom salt bath or some way to get more magnesium into your system. And a lot of people find benefit with that for these palpitations. Other arrhythmias like AFib, atrial fibrillation, or SVT, supraventricular tachycardias, those are a little more serious because those aren't just a nuisance of a feeling, but those actually have other health concerns and repercussions down the road. So even more so, I will make sure their electrolytes are replenished for those situations. And also, interestingly, how lifestyle plays into this. I mean, the risk factors for AFib are being overweight, having high blood pressure, not exercising, and having a high sugar, high carb diet can play into all that. And so that's why when people ask me, does a low carb diet treat atrial fibrillation? Well, I can't say that it specifically treats the electricity imbalance, I guess, or the electricity short circuit. But what it does do is it treats every single one of the risk factors for AFib, and therefore it can certainly make it less likely to happen.
I mean, if you think about it, magnesium. Where do you get magnesium? Well, leafy greens and the chlorophyll. I mean, it's part of you need some vegetables and people don't consume a lot of those. But on top of that, you have insulin resistance, which just for the fact you have insulin resistance, the majority of the population, you're not going to be able to absorb the amount of magnesium or potassium you once did. So I think, just my own viewpoint, this is my guess, I think it's partly not consuming the right foods, but partly the insulin resistance. Even if you do consume it, it's not going in like it should. So you have to do more. So yeah, interesting point.
Yeah, great point.
What about, have you ever run into a situation where you assess someone with angina and their arteries are clear?
Sure. Yeah, that does happen quite a bit. Yeah, so there's this condition called syndrome X or microvascular disease. It's got a number of different names where sometimes the main arteries look clear, but the very distal arteries that you can't see very well could have plaque buildup, or even the arteries could be spasming, and those can both cause angina. So, the treatment, cardiologists tend to lose interest then because the treatment is no longer stents. It's no longer these cool procedures we have to open up arteries. The treatment then is focusing on lifestyle, maybe some medications, maybe stress management, maybe electrolyte replacements. It's getting a little more detailed and actually a little more challenging than just going in and putting in a stent. So there's a lot more involved from that standpoint, but it's something that happens quite frequently. Yeah.
Wow. And then from your experience, you have a chance to try different diets, and you're obviously right now you've just basically stumbled or researched and found low carb is really effective for your clients. What, from a cardiovascular standpoint, are you just finding like they're responding way better than the other diets? I mean, I just wanted to kind of just get, you touched on it, but I just wanted to know what type of effects are you finding when you're coaching these people that had, I'm sure that you probably, most of the people you're coaching have cardiovascular issues, I'm guessing, and then you coach them, you change their diet, and then you see changes.
Yeah. So there's actually a mix of people who I'm coaching. A number are prevention. They say, I just don't want to develop cardiovascular disease, or I have high blood pressure or high cholesterol or something, and I don't want to develop the cardiovascular disease, or I just want to be healthier. So I have that subset, and then I definitely have the subset of people with cardiovascular disease already. And it's interesting, and this is one of the challenges when you say, how are they improving? How's their cardiovascular disease improving? Well, that's a tough metric. I mean, that's something really hard to measure, because you're not going to do angiograms on these people on a regular basis because it's got risks, it's invasive. You could do CT scans, but you're not going to really see regression of plaque to a substantial amount. Even these studies in the past that say, vegan diets have shown a regression of plaque, it's an inconsequential change in the plaque volume that really, by today's standards, would not be something of real interest. So it's incredibly hard to show regression. And that's where I like this test, the carotid intima media thickness, the CIMT. It's a specialized ultrasound of your carotid artery that measures the thickness of the wall, essentially, of that artery. It's been knocked down a little bit as a test because when you compare it head to head with a calcium score, the calcium score has much better predictive value. But where I think the CIMT has its value is following it over time. Whatever your initial value is, okay, you don't have to react too strongly to that value. But what happens over the next 6 months to 2 years? Is it thickening, or is it actually thinning and regressing? And you can see these dynamic changes much more clearly. So that's one marker you can use. And I have seen some impressive results in a number of patients when they go low carb. I've not seen severe progression in almost anybody. Most people probably stay the same. But then you look at all the other risk factors and the markers. What's their blood pressure? What's their waist circumference? What's their metabolic health from an insulin and glucose standpoint? What are their inflammatory markers doing? And granted, these do not guarantee that their cardiovascular disease and their vessels are improving, but these are the best markers and predictors we have to say what kind of impact are you having on your overall health. And as I'm sure you know, with a low-carb diet, the majority of those improve.
Oh, yeah, absolutely. Dave Feldman, right?
Of course. Yeah, he's great.
So Dave talks about, he's like a human guinea pig, and he went off the keto plan, okay, for 6 weeks, I think it was, and he showed before and after his I guess his arteries in the coronary, the carotid space started to thicken. Did you ever hear that story?
Yeah, so that's the CIMT. So that's exactly the test I'm talking about, the CIMT. His CIMT went up significantly when he went on his sort of high carb, standard American style diet.
Incredible.
That's scary. It was scary to see.
Especially in 6 weeks.
Yeah, right? So quick.
I mean, like, this is what happens, right? Someone does keto, and right around Thanksgiving, they go off keto until New Year's, right? So they're just going to go off of it, and they don't realize what's happening. You're just clogging your arteries, or at least thickening your arteries and obstructing blood flow to your brain.
Right. So important to differentiate. That does not mean a plaque or a clog in the artery, but that is an early sign of vascular disease, vascular damage, and the natural progression is down the road to develop plaque in that artery.
Especially since you're setting yourself up for inflammation internally, and that from that inflammation you have all this healing, this patching effect of all the other things that can then create the plaque.
Right, exactly. And that's why the people who I work with, I counsel them saying, look, we don't have 20-year data to say this diet is going to reverse your arterial disease. But what we have are all these tests that we can measure to show that they are improving. Or if someone comes to me with an LDL of 250 and says, my doctor says this is killing me, and I say, look, there is another perspective here. And that other perspective is we measure all these other tests and follow them to see if we have any sign of progression or worsening of vascular disease. If we do, okay, then we better react to that pretty seriously. If we don't, then we continue to have this conversation of, well, what kind of evidence do we have that this is helping? What kind of evidence do we have that it's hurting? Because it's the overall health and life of people that we're concerned about, not a specific number.
Exactly.
Yeah.
Well, I'm really excited to have you come out and share some more in-depth information at our summit. Last year we had 500. We're going to have 1,000 people.
Wow.
And you're gonna be actually shocked just to the quality of these people. It's like there's such an incredible group of wonderful people that are actually they're watching right now. And so we're going to make it mandatory that everyone watching has to come out, and we'll meet you in person and have a great time. But I think what you bring to the table is like you have experience. You're in the trenches. You basically you're dealing with the number one thing that people die of. So I think it's going to be very valuable to have you share your data. So I appreciate you spending time in your busy schedule now just to do this interview. And we'll definitely do some more as well.
Great. Well, I appreciate the opportunity. I really look forward to that conference later this year. Thank you.
Absolutely. Hey, if you wouldn't mind to give me a thumbs up and like this video, I would really appreciate it.